I'd like to introduce you now to Katy MacLeod. She's a research and peer engagement programme manager for the Scottish Drugs Forum, and she's going to talk about getting it right for women with a drug problem issues, and improving practice. Thank you, Katy.
Thank you. This is where you realise that you have a really loud voice, so this is why I'm going to stand a little back from the microphone. Being Glaswegian has its benefits sometimes, but not always when there's a microphone. I'm going to speak about women's experiences of accessing services, and this work is basically taken from a number of pieces of peer research and evaluation work that I've been involved in, and there's many of our researchers in the room as well, so I'll have a wee mention of them at the end. But if you do get to speak to any of our peers and staff involved in the programmes, please do, because they're involved in fascinating work. But there's a few different things that I'll be garnering women's experiences from. So some local area service evaluation work. So we've been doing a specific piece of work on women's experiences. We've also looked at pregnant women's experiences as well in some local ADP areas. We'll also be drawing on the baseline study that we published a while back now on medication-assisted treatment as well, so living experience perspectives, and also a piece of work where we worked with homelessness and substance use in collaboration with Health Improvement Scotland and Homeless Network Scotland. So it'll be voices of women from all of these pieces of work. So we've talked a lot about trauma, adverse childhood experiences and poor mental health, and just that overlap as well. So, certainly in terms of looking at across all our peer research data, trauma and mental health issues are disclosed by the majority of women. So it's right through all of our samples. And certainly when it comes to homelessness, domestic abuse was a key factor that was connected to women's homelessness. So either where they became homeless, that was the reason why, or abusive relationships they became involved in through the experience of being homeless. So women talked about, hostels and things like that, just being quite risky places for them to be in at times. And then women who had experienced trauma often reported mental health issues as a result of that trauma. So post-traumatic stress disorder, complex PTSD, bipolar, schizophrenia, depression, anxiety. These were some of the women's official diagnosis that they shared as well. And many, many women talked about feeling that they had mental health issues that had been undiagnosed as well, and it was actually really quite difficult accessing mental health assessments. Self-harm and substance use were key strategies cited by women as well, and people described effective supports being sometimes really just simple stuff like just adequate time to talk to their workers, but people did talk about more specialist support such as psychology. And actually for many women, when they talked about needing mental health supports, they had no idea of the range of supports that was out there at all. They just hadn't had that information as well, but there really was a consensus that their mental health needs were not adequately addressed and assessed for as well. So I'm going to share some different quotations, and again, just to sort of, as with the last speaker, just to sort of say we recognise that these are real stories of real women, and they're quite hard-hitting, some of them as well, so just to mention that and acknowledge that as well. So the first woman's just talking about her initiation into drug use as well, and just feeling that it took the pain away. She didn't feel any hurt, didn't feel sadness, and said, I need to keep like this, I need to stay like this as well. And then just the second quotation, just the significant trauma that this woman had experienced. So extreme violence, and had to flee for her safety, and that led to her being homeless as well. And many, many stories of women where they had to flee with children and things like that as well. So really hard-hitting things. Other women talking about their experiences of just the experience of trying to actually get help. So just the hoops that you need to jump through. And I should say as well that staff often shared those experiences where we did focus groups with staff. So they talked about it being really hard to keep appointments when you're paranoid and anxious. So, much like we heard earlier on from Adam about those kind of relational stairs and escalators as well. And this woman in particular felt that there was better support around for her when she was pregnant. What a lot of women who were pregnant said, that they got great support maybe during the pregnancy, but afterwards it just went. So people talked about specialist midwife services, but actually a lot of the women talked about a need for specialist health visitor services over that longer term as well. So only 10 days afterwards were they getting that intensive support, and some of the women felt that it really left after that. And in terms of access to services, women talked about real specific challenges for them as women. So they didn't have any idea often the available services to them, the length of waiting times, particularly when we spoke about mental health as well, was really stark. Just the practicalities of going to services, so things around opening hours, challenges with travel, the caring responsibilities, and again how that impacts on your ability to attend an appointment within quite core working hours as well. And then the kind of gender specific stigma that can follow for women as well. So some women shared that they felt they were particularly stigmatised as women. So women were sort of viewed in certain ways, and certainly women with children, there was a greater sort of stigma on them, and we'll come to that a little bit later. The impact of COVID-19 was another factor within this as well. So for many women, this made relating to services a lot more difficult, but also important to acknowledge for some women there was some benefits of some of the lockdowns, so things like relaxation with being able to pick up prescriptions, things like that, that worked really well for some women as well, yet some people felt attending the chemist every day was actually a helpful anchor for them, so it was quite mixed. So there was lots of learning during the lockdown for services as well. So this woman's talking about when on a waiting list as well, just the communication that is around when you are waiting so that you don't feel forgotten about. The wee phone call, there's just the small things that we do and how important that actually is, and that your referral is still there. So when women talked about what they needed from staff, sometimes it was really, really small and basic things. And this other point as well is just talking about referrals, and again the hoops to jump through, and it can take such a long time to build up that therapeutic relationship. So this is from the staff perspective, and this person's saying that you need to speak to the person, you need to speak to this person 9 times out of 10 depending on circumstances. They're just like, that's too much. And then just this point on stigma, so around women with a drug problem. People feel she's strong, she's not got any issues, or she shouldn't have issues, and things, as I mentioned, in the chemist as well. So we saw the kind of obvious stigma, so different queues, people talked about that within waiting rooms, different doors to enter premises and things like that. So just the subtle stigma that arrives the minute you arrive in the service as well. So, being discriminated for standing outside, for example. This quote, and I remember reading it again when I looked over my slides this morning, and it just really sort of hit me, because actually I've had this experience as well of referring into systems where people have been given a kind of traffic light system, and this client was actually told over the phone that they were down as a green, and so there was no concern for their well-being. So this was the worker actually shared this with them, and as they say, how can you tell how I am over a phone, and thinking about the COVID period as well, where someone might have been doing really well but actually was in a high trigger point as well, and just that maybe not being acknowledged as well. So some real gaps or holes, as my colleague Jason alluded to as well. And in terms of medication assisted treatment, really important to note that that was a key part in many of the studies, not just the medication assisted treatment piece of work. It was a key part of treatment and recovery for women, so it was a real motivator to engage with services as well. That could be really positive, but there is, and you'll see some of the quotations, there was some concern for women that was sort of sometimes used in a more punitive way as well, that they had to do certain things or their prescription could be removed. And so there was those two sides. But women cited various issues with MAT, which centred mostly around their access and choice. So again, those long waiting times, lack of choice, in medication type, but involvement and communication as well, just, people not understanding, any of the sort of choices around that they maybe had, or reasons why one type of medication may be better for them as well, just having very little knowledge. And also about dose as well, and feeling just really like lack of involvement and control. And again, that was mixed. Some women felt more involved, but for women that found it difficult, these were the kind of things that they said. Definitely there was a number of women that talked about the stopping of prescriptions and unplanned discharges as well, and that was also mentioned by staff, some staff saying women just disappeared actually, and that was a real challenge as well. So some quotations from women as well. So, women sharing they didn't know how much of an informed decision it was when they first maybe were in the service, and so maybe they were given some options, but it wasn't really explained in a way that they understood, or they weren't actually in a state to understand as well. And then someone talking about, they continued with the service because of their prescription, but not actually for the support that they experienced. They didn't actually feel that they got much other than their prescription at that point. But still important to note that that was a kind of life-saving element for them as well. And then this other woman talking about basically that sort of feeling of control as well, that the prescription is waved in front of their face and feeling that it can be removed at any time, and just the sense of fear and the re-traumatisation that these sort of coercive measures can have for women as well. So again, some challenges as well. So if you missed an appointment, you would panic, and then you would be worried, is this going to be removed from you? And just women feeling that that was really wrong, but also not feeling that they could speak up. And I think this is from a staff focus group as well. So again, thinking about women that have been discharged as well, and actually staff saying, like, we know that this is unhelpful as well. We know it can lead to overdose, things like that, and then can mean women transition back onto more risky substances as well. And sometimes they've not even been informed that they've been discharged from the service as well. So moving on to support. Regular contact was really key for women, and good communication from services. So all that sort of stuff on the waiting list example, so checking in, just that regular communication. There was so many examples of women saying that they left messages for workers were off sick, were on holiday, and no one had told them. So a worker might be on long-term sick and they just hadn't had any contact from the service. So again, many women just dropping out of service just due to lack of contact as well. So maybe some internal issues with handovers and things like that as well. And some of the things that the women said when workers did call them, remembering small details about them, remembering the name of their children and things like that, and just doing that basic check-in stuff, that was so important to developing that therapeutic alliance. Strong relationships with workers was key. That was underpinning everything. So really what women talked about in terms of feeling understood and accepted as well. Really important to say that women really valued the lived experience of workers as well. So that was a really key part of what women said helped them feel safe as well. What was interesting is when we asked about female workers, it was really mixed, and we found it just could totally depend. We didn't get any clear themes on it. At first we wondered, was it an older or younger women sort of balance? It just wasn't really clear in the data that we had. But what women did seem to agree on is having that option, having that choice. So being offered that was really important. So for the women where it was important, they talked about just maybe feeling a little bit unsafe with men and feeling that it was really important to have that option. But for many women, they said the gender of the worker was much lesser importance to them than that really good therapeutic relationship. That was the real key. And, kind of adding on from what we've heard from the other speakers, short-term crisis support, that wasn't what women were looking for. They needed that longer-term support, someone to be checking in with them over time, and that to be consistent as well. So again, we've got some stories of the women as well. So this particular woman's talking about the drug part of treatment. So I think this was a woman that had some input from homelessness services and actually had really positive experiences of that, but said the drug part of their treatment was quite difficult as well. So this issue with like workers going off sick and then just like feeling like she could never get hold of them. And just the importance of things like empathy as well, just how that underpins everything that we do. And then the lived experience element as well. So someone that's been there, that knows what it feels like, that was really, really important for women too. And just a couple of final things about, you know, sort of women-only workers as well, so female workers, but then also just that point about therapeutic alliance as well. The point about support disappearing, that also happened in criminal justice services as well. So when they were on an order, maybe getting lots of regular contact, but again feeling that it took them to get a criminal record to get that bit of support that they needed as well, and just the fear with it disappearing. So kind of, so I'm conscious of time, but just to spend a couple of minutes just talking about the role of children and family as well. So some women were really motivated to seek support due to their caring responsibilities, but of course it could be a massive barrier for some women who were mothers. So there was, for some, they talked about just the practical challenges, but for many women there was such a fear of social work involvement. So whether that was something that they'd experienced in the past or just fear of having heard about stories. So not all of it was necessarily through experience, some of it was imagined. They believed that that's what would happen. So they described the feeling that they couldn't be honest, and if they did, it would result in them losing their children. So they were so worried about that. And they really identified a clear need for early intervention and ongoing support for women, particularly where they've had their children removed. So thinking about women that have actually had that experience. So again, some quotes about that as well. So not telling the truth for fear of losing your kids as well, and feeling that although they get on well with the worker, the consequences of telling the truth are too great as well, and that leads to them not feeling able to be honest as well. And again, some sort of staff thoughts about that, and I will be sharing the slides with people as well. So just to finish off with what women want, these are the kind of things. So some options of women-only supports or women-only spaces, definitely about wider and faster access to specialist services and intensive support options as well, but bearing in mind not all mental health support needed to be specialist as well. And a full range of harm reduction and abstinence-based supports as well. So women gave a big, long list of everything from drug consumption rooms, right through to residential rehab. So they wanted to be able to access the full package of what was available to them as well. Definitely comments about early intervention, that longer term care as well, consistent drug treatment support, which included that contact, that review, that follow-up with drug services that they didn't need to chase for. Thinking about childcare within that service. Jason touched on the simple stuff like bus passes as well, but also like out-of-hours supports as well. And then thinking about women that live in more rural areas. There was some women taking like 3 buses to go to appointments with no bus pass as well. And definitely more lived experience workers. And really just to sort of finish off and say, of course, within this wish list, and certainly from a staff perspective, what staff were saying is we don't have enough resource, you know, like we can, you know, adapt and look at our sort of budgets and think about, you know, smarter ways to spend, but actually we need more resource and services as well. So that's just a kind of few thoughts. And really just to acknowledge, like I say, the various peer researchers that are in the room today with us as well, and all the health board areas, Health Improvement Scotland, Homeless Network Scotland as well, and of course the women across all the different evaluation sites as well. So yeah, thanks very much for listening, and if people do want any specifics about any of the individual studies, come and speak to me at the break as well. So thanks for listening.